Good afternoon, and welcome to the University of Toronto Mississauga's Alumni Webinar Series. My name is Kristen Lovell, and I'm the Director of Alumni Relations here at the University of Toronto Mississauga. This is our second webinar in a newly launched online series where University of Toronto Mississauga faculty will address topics relevant to the COVID-19 pandemic. Before I continue, I just want to mention that we had a webinar on Monday, and at one point Zoom kicked us out for just a few seconds. So if that does happen today, hang tight, don't worry, just be patient, and it'll come back on. Today's moderated discussion is about the history of stigma and blame during past pandemics, the similarities to the COVID-19 pandemic, and how we can respond to the influence of fear and stigma. And I'm delighted to introduce today's speaker, Dr. Madeline Mant. Hello.
Hi there.
Dr. Mant is a research associate and lecturer in the Department of Anthropology at the University of Toronto Mississauga, where she teaches anthropology of health and anthropology of infectious disease, drawing upon historical plagues for lessons to contextualize current events. Her bioarchaeological and medical historical research concerns the health of vulnerable and marginalized groups in the past. Most recently, she has studied the working poor of 18th century London and 19th century North Atlantic merchant seafarers. Currently, she's studying health and disease at Her Majesty's Penitentiary, the oldest operating Victorian prison in Canada, in St. John's, Newfoundland and Labrador. And now, please welcome Dr. Mant for a moderated discussion on the history of stigma and blame during past pandemics and its impact on our current situation. Welcome, Madeline.
Thank you for having me. I'm so excited to be here.
We're very excited to have you. And I just want to let the audience know that if we have time at the end, we will open it up for some Q&A. So if you have any questions, feel free to submit them. So we'll get right into our questions. To start off, can you just tell us a bit about your research?
Yes, I'd love to, which is such a dangerous thing to ask somebody who's stuck in their own house and who loves to talk about their research. So if possible, I could share a few slides with you.
Absolutely, that would be fantastic.
Awesome. Okay, so I'll get this started and you can just let me know how it looks. So,
and then just go to the slideshow there. Perfect, it's there.
Wonderful. So, so my research is an interdisciplinary blend of anthropology and history. So I am always focused on health experiences of marginalized and vulnerable individuals in the past. So I've been asking a lot of questions that come down to whose story has not been told, whose bodies are missing, and what stories can we learn from looking at different sources of data, such as human skeletal remains, as well as archival records of institutions such as hospitals and prisons. So you mentioned there the working poor of London in the 18th century. And so I've got a slide here representing some of that research. This work was a lot of work on fractures in the skeletons of men and women who lived during the 18th century in London, UK. So what you're seeing here are some violence-related injuries or marks in the skeleton that can provide clues as to some of these sort of social and cultural interactions, here particularly revealing of the male. So I chose some really exciting results. You'll see there on the left, there's a skull with a nasal fracture. The bottom left, that's your first metacarpal, so the bone in the base of your thumb. It shouldn't look quite so swollen on the right side there. The base of that has had a healed fracture. So what we're seeing here are boxing injuries likely related to the style of boxing in the 18th century. Top right there, you'll see it's bare knuckle. You have the hands placed vertically, the palms and digits placed immediately like this. So we do find evidence in both the bones as well as hospital records of the 18th century in the bottom right there, showing evidence of some of these types of violence. So that's, there's some infectious disease in that project as well, but in this particular case, the trauma was the most exciting. Another project I've been working on is looking at the merchant marine in the 19th century. So during the 19th century, the British Navy kept really impeccable records. So there's been some wonderful and very detailed studies on health and disease in the Royal Navy, but the mercantile seafarers or folks that were working on merchant or trading or passenger ships, even during the 19th century, there were complaints that we don't have data on their health and disease rates and we're losing information. So I went through and cross-referenced both hospital records in England and Newfoundland and looking at that North Atlantic trade, as well as logbooks and crew list agreements like you're seeing there on the right, talking about the ability to reconstruct some journeys of these individuals as they sought care. So yes, there were many cases of sexually transmitted infections. That sort of poxy sailor stereotype does come from somewhere, but it's actually respiratory diseases that were bringing a lot of these men into the hospital. So there's some really interesting untold stories there. But the most recent project I'm working on is looking at Her Majesty's Penitentiary, which is indeed the oldest still operational Victorian prison in Canada, following the closing of the Kingston Penitentiary. So Her Majesty's Penitentiary, we were able to look at who's on the sick roll, which prisoners are being transferred to the hospital back and forth throughout the 19th and early 20th centuries. What you're seeing there in the bottom right is a surgeon's note from the weekly visits to the hospital. And he is saying here, some provision should be made for allowing Joanna Hamilton more exercise than she has at present. Her health cannot continue to endure the solitary confinement to one cell, which she has been undergoing up to the present time. So this is actually, we're able to explore chronic disease, infectious disease, as well as mental illness in the past. So this is an ongoing project that is very, very exciting. But my work in terms of what I'm teaching is looking at infectious diseases in a broader sense and trying to bring some of that back to individual bodies to teach students about some of the, both the biological and the social aspects of what infectious disease can teach us.
That's very exciting. Can you tell us a little about the Anthropology of Health specialty at UTM as well?
Definitely. So I've just listed some of the courses that we teach here. So Anthropology of Health at UTM, the idea is to get students thinking about how to contribute to health challenges by bringing an anthropological approach, because what we do well as anthropologists is see issues really broadly across time and space. And so I haven't yet found a domain of health, either clinical or services or policy, in which researchers aren't open to engaging with some of that anthropological theory and method, both to define and then to understand some of these larger scale problems. So the classes that we have currently operating are what you see there. And so the questions we bring up in a lot of the anthropology of health classes are, how can we look at biomedicine or Western medicine as one form of medicine? How can we trace the roots of what we consider to be normal? You know, what is it that we assume? Why do we assume the clinical encounters we're having should be a certain way? And of course, a lot of this can be traced to thousands of years ago. So we're building skills for students who want to go into health careers, social work, personal support workers, et cetera, but also for students that are just interested in broadening their understanding of the society in which we're living and how we're negotiating health and illness. So I think everybody should take anthropology of health classes. Obviously, I'm always a cheerleader for this stream, but it really does help you to contextualize what you think about your own health experiences.
Okay, thank you for that.
Yeah.
Now, COVID-19 has been called unprecedented, but looking back in time, we've been through very serious pandemics. Is it really unprecedented?
It's so interesting the way we use language. We'll come back to this several times, I think, over the next hour. But what's really unprecedented is the fact that we are able to mobilize globally so quickly and to communicate with each other so clearly, because there has been a lot of discussion in the media about how globalization has driven COVID-19. And there is a lot of value in investigating those connections. But I think it's really important to note that diseases like the Black Death and diseases like syphilis that were spreading across Europe in the 14th and 15th centuries were spreading along trade routes. So globalization isn't really as new, I think, as we think it is. 1918 influenza was able to spread west across Canada along the railway lines. So movement of goods and people have been moving diseases for many, many years. There's lots of work that's been done on the connection of war and disease. The greatest invisible foe doesn't tend to be a soldier on the battlefield, but it's actually the microscopic invaders they might be bringing with them. So we've been moving across the landscape and moving diseases with us for a long time, but a couple of examples I pulled up here, quarantine is not new. Quarantine, I mean, this is a notice from the 50s here about polio, but ships arriving in Venice in the 14th century were asked to stay at anchor for 40 days to ensure that any type of disease that was on the ship would have a chance to sort of burn its way out. So quarantine, the word, comes from the Italian phrase 40 giorni, which means 40 days. So this is not new. The idea of staying in your house, being careful and avoiding contact with people isn't something that we've suddenly invented. Masks are also not new. This is a notice here on the right from referencing 1918 influenza, but the idea of homemade masks, my partner's mom just sent us some nice homemade masks the other day. So doing crafts like this or working like this isn't new. We see the sort of modern development of PPE or personal protective equipment masks starting really in the 19th century in terms of masks that we'd recognize today against plague in Hong Kong. So the logic behind social distancing isn't something new, but the way in which I think we're seeing it all happening at once and we're able to talk to each other across the world about it is truly what makes this a modern plague.
Okay, thank you. I think my next question is a pretty big one. What do you think we can learn from past pandemics?
Oh, I think we can learn everything from past pandemics. This is why I spent a whole semester talking about this, and I still can't cram it all in, but I'm really excited to tell you a few things today. So plague isn't a really, really old concept, right? So I've got here, this is a 16th century painting about the triumph of death, and this is in reference to various ongoing epidemic plague outbreaks. So plague, the word comes from Greek plaga. It means wounds or blows, but it also means misfortune. So it's this really emotive term we're using with the notion of like evil and calamity and foreboding in it. So a plague is much more than just a biological event, right? They have social qualities. There's a social construction to plagues. And what's really important about them is that plagues or epidemics can reveal these larger frameworks of meaning in society. And that's definitely something we're seeing today. And I know we'll get to that as we talk through the rest of this webinar. But we can learn a lot about the development of structures we see in place today. And so I mentioned already the development of PPE. And so I want to give you a really classic example of personal protective equipment, which is our classic plague doctor. So imagery like this is coming from the 17th century from outbreaks of plague. This costume, or at least an early version of it, is credited to a French physician from 1619. And so this protective suit was meant to have a waxed fabric overcoat. The mask has these glass goggly eyes in it. And we've got this beak-shaped nose. The thing that everybody remembers, of course, is this long beak. And the beak was stuffed with herbs and straw and spices. And you see that the doctor there is carrying this cane. And the cane was used to examine patients and to direct them without having to touch them directly. There's been some ideas that potentially the doctor could feel the pulse through the cane, but also keep their distance from a patient. So this beak is full of berries and juniper and garlic and camphor and all these wonderful smelling things, because there was a belief at the time that miasma, or bad air, was the vector for disease. So rotting vegetable materials, or when you burst a bubo and pus splits out of it and it smells terrible. The idea was the disease was in the smell. So if you could protect yourself from the smell, then you protect yourself from the disease. So of course, this is ages, well, not ages, but hundreds of years before germ theory is accepted. But the idea of keeping yourself away from these products of disease makes some sense. And so there's been, I think the plague doctor gets a bad rap. This idea of that sort of quack doctors in the past who don't know what they're doing. But during times of epidemics in Europe, so we know definitely in France and Italy, towns would hire these plague doctors because a lot of the practicing physicians would flee. A lot of the rich would pick up and go when plague would arrive. And so instead we're hiring I think in Holland, there's a fruit seller that is hired to be a plague doctor, or kind of second-rate physicians, people without their own practices, or medical students would be hired on for a certain period of time and paid a monthly stipend essentially to go and deal with the plague dead and to go and deal with people that were suffering. So these individuals were registering deaths of plague victims, giving us the very first epidemiological data sets to actually know anything about plague in the past. So I think putting them in their context helps. And so one big lesson that I try to bring my students when we talk about the past is you have to put it within its own context. Looking at the past and saying, well, they just used leeches for everything, what fools, is not a useful way forward. There's a presentist bias to that. So looking at some of these characters like the plague doctor, I think really gives us a good view into people doing the best they can with the information they have at the time. But in terms of blame, and I know that's a major theme we want to talk about today, I do want to talk about syphilis. This is a topic that my students always really love to talk about, or at least I like bringing it up to them to make them uncomfortable. But syphilis and blame is a really kind of provocative example of this. So syphilis emerges as a disease that we recognize as syphilis in 15th century Europe. It shows up in Naples, Italy at the end of the 15th century. Now, King Charles VIII, I'll have to check that. King Charles VIII, I think, of France had invaded Italy in the 1490s. So soldiers are fighting on both sides and this disease starts to erupt, and they referred to it as the disease of Naples. And it started to weaken people and it led to casualties on both sides. So as armies were disbanding across Europe and returning to the homelands, again, that idea of globalization, right? Driven by war in a lot of cases, the disease starts to spread across Europe. And it leads to this major epidemic of what seems to be this new disease. So what's interesting about syphilis is that these names start to get to apply to it. And all the implications are that it comes from elsewhere. So the French call it the Italian disease, and the English and the Germans and the Italians call it the French disease, and the Russians call it the Polish disease, and the Polish call it the German disease. So you can see that it never comes from home, right? The Japanese refer to it as the Chinese disease, the Dutch and the Flemish and the North Africans, the Spanish disease. The Middle Eastern individuals call it the European pustules, which is one of my favorite ones of all. So it never comes from home. This disease that is attached to sickness and to sexuality, of course, can't possibly be coming from our people, right? So there's a question of othering and stigmatizing and blame. Now, we know today, of course, this is a bacterial infection. Treponema pallidum pallidum, it's a bacterium. A bacterium itself doesn't carry any kind of moral or ethical meaning to it, but because it's a sexually transmitted disease, we start to layer on these moral judgments. And so these images I'm showing you here, I could have chosen hundreds of different examples to show you today, but the propaganda pushed by the Allied governments during the First and Second World Wars is all about venereal disease, which at that time they weren't always connecting, or they weren't always separating syphilis and gonorrhea. So the idea of just getting some sort of venereal disease. An incredible amount of propaganda was put out during the First and Second World Wars. This idea that the Allied forces would be weakened by the sort of moral problem or the moral chancre of indiscretion. And you get these really powerful and really stigmatizing images, particularly against sex workers, because there's this moral and physical shame of contracting an STI. So it's interesting in terms of, we talk about the 15th century, we talk about the 20th century, the messaging is really, really similar. Now, in terms of blame, I just want to throw it back to the Black Death again. Everyone enjoys learning about the Black Death. Again, this pandemic from the 14th century. Again, we know now it's a bacterium. It's Yersinia pestis, spread by fleas that live on rats. We have that information now. But in the 14th century, of course, we don't have that information. We know it's coming from somewhere else. We know we're terrified because also it killed everyone. There was no acquired immunity, which is a big parallel we do actually see to COVID-19, right? This thing is coming through. Everybody is potentially susceptible. There's no acquired immunity. The rich and poor alike can get it. But vulnerable people were blamed. So what the image you're seeing here on the left is actually a group of Jewish people that have been gathered and are being burned alive because they are being blamed. Of course, maybe they were bringing the disease. So vulnerable groups have been punished throughout history. So the examples I'm bringing here of sex workers and Jewish individuals, this is ugly history, but it's something we have to reckon with, the idea that it's very simple to point fingers and place blame, but it has powerful repercussions, particularly for vulnerable and marginalized people. Now, plagues also, beyond the blame and aspects, have really incredible legacies. There's lots of work that's been done discussing how the Black Death paved the way for the end of feudalism, which is a very complicated economic argument. But there's actually, on the right here, there is a Catholic patron saint of the plague, which I think is absolutely fascinating. We've got this protection against the plague. You can see he's lifting his outfit there to show you the bubo scar on his thigh. And so it's proving that he, of course, had the bubonic plague and he had survived. But in terms of behaviors that come out of plagues, I think there's a lot of parallels we can draw to human behavior through time. So when the Black Death arrived, 1347, 1351, a lot of people picked up and left. People that had the ability to scoot did. And so when we hear about in the news, folks trying to get up to cottage country and that sort of thing, there's a lot of similar ideas of just trying to get my family away from the sickness of the city, right, to the kind of airs and waters countryside. This reaches back to Hippocrates talking about the health of the open air and the open water. But during the Black Death, there was a lot less movement between towns. People were quarantining. There was a fear of strangers, fear of people coming in from elsewhere. But the opposite reaction also happened. Some folks said, well, I guess it's the end of the world, and started to party it up. There actually was papal officials had to ask people to stop fornicating in graveyards. And in that way that when you see, a warning label on something like, do not iron this while you're wearing it, you think, who ironed your shirt while you were wearing it? But somebody must have, to mean that we have to have that warning. It means people were having sex in graveyards in the 14th century because they thought it's the end of the world. So I think that's kind of a fabulous bit of history. But I think what we can learn is really that somebody is always blamed, and it's our responsibility to pick apart those threads. So be careful not to allow diseases to become associated and intertwined with morality, because these social attitudes and medical practices do start to reflect those cultural fears about contagion, about sexuality, and about death and disease.
Very exciting, thank you. Given the concerns about blame, why did we call the 1918 flu pandemic, why do we call it the Spanish flu? And how do health issues of marginalized people play into the issue of blame?
That's such a good question. The Spanish flu question is such a good one. And a lot of people ask that immediately. And I think it's a really, really great, again, it's just this little historical nugget of information that when we can have pub trivia again, you're going to be happy you have, because Spanish flu is called Spanish flu because Spain was neutral during the First World War. So when cases started to arrive, their media was openly reporting on this. And there were government officials and individuals that were high up in the royal family that were catching Spanish flu, or what was then started to be called Spanish flu. They were getting influenza, and it was being reported on openly. So people were talking about it. Whereas the Allied governments, so we're talking about Britain and France, at the time were censoring any material that was talking about weakening or talking about medical cases. And so information that was spreading worldwide was only talking about Spanish cases. And so it became known as the Spanish flu as a complete misnomer because of Spain's involvement in the Great War. So again, that when we talk about stigmatizing or attaching things, that's just a misnomer. It's just sort of kind of a historical mistake, but so it becomes misunderstood as the origin, when in fact, by the time Spain was actually reporting cases, it had already been spreading through France and the United States. So it's just a misnomer. But I really like the question you're asking about how do health issues of marginalized people play into this, because we're not only talking about individuals who are marginalized further because of talking about blame, but groups, I think the really most powerful example that I talk about when I'm teaching this is talking about HIV/AIDS. So I've got a Keith Haring little piece here. There was a sense in the 1980s that the great pandemics were done, that biomedical interventions and innovations had moved beyond the destruction of pandemics, because this is coming, remember, right after the eradication of smallpox. So, I mean, which truly is one of the most amazing things humans have managed to do, is knock out smallpox. So the last natural cases of smallpox have been wiped out. And there is a sense, you read in the literature and you read about the news at the time, and it's just like, we have conquered death, we are all powerful, and it's very, very exciting. So when in 1981, we start seeing these cases of what we know now to be HIV/AIDS, it was devastating for morale in a lot of ways. And it meant that blame was really, really, really heavily laid upon the groups in which this disease first started to show up. So it's a global pandemic, it's still ongoing. And so when it first emerged in the United States, it was actually labeled GRID, which is an acronym standing for Gay-Related Immune Deficiency. It was also known as 4-H. People were talking about, well, what are the groups that are suffering from this? Well, it's homosexuals, heroin users, hemophiliacs, and Haitians. And this labeling is so hateful and so limiting. And when I teach this class, I have cried every single time I have given this lecture, because it is so, it makes me so angry, and it makes me feel so helpless to think that people who were suffering were having these labels laying upon them with such moral anger, coming from people who couldn't understand why it was we should be trying to help folks that were dealing with this, at that point, death sentence of a disease. So AIDS, finally, the term was coined in 1982, but the stigma did remain, and we're still fighting misconceptions about HIV/AIDS. There's been some surveys done in both North America and in Britain over the past few years, asking just people on the street, just a convenient sample of people, about some misconceptions. And a disturbingly large percentage of people still think you can get it from kissing somebody, or from a toilet seat, or just from casual non-sexual contact. So there's clearly so much more work to be done, despite the fact that there's actually a lot of good news about the cases of HIV/AIDS now. We, of course, have antiretroviral therapy. We have the Berlin and the London patients, which are two individuals that are now HIV-free because of a bone marrow stem cell transplant. So really, really exciting innovations. There's also prophylactic drugs like Truvada, the PrEP, or pre-exposure prophylactic, to help keep viral loads down or completely gone. So it's really exciting, and there's a lot of really positive aspects that have come out from, I think, a reckoning of dealing with how we have categorized and characterized HIV/AIDS. But this particular image is so powerful. The ignorance equals fear, and silence equals death. So talking about it and letting people know what's going on is so important. But of course, it is difficult to be the person who's saying, I am sick and I need help, and have somebody say it is your choice or your lifestyle that has caused this. It is absolutely devastating. So when we look at how language is used to talk about disease, we need to check again and again and again that we're not coming from a place of bias, because bias is so devastating and is so dangerous to people's health on an individual basis.
Wow, this is very eye-opening, Madeline. I wish we had 2 hours to talk with you. Another question, what similarities and differences do we see between pandemics from the past and today?
Yeah, there's lots. And so drawing sort of direct lines, I never find to be that useful, but that phrase of history doesn't repeat itself, but it rhymes. Boy, howdy, we see that with COVID-19, we see it with everything. And so when I was thinking about this question, the example that popped up immediately was, I thought, oh, I can use my Elvis picture again, because I love this one. This is Elvis. Oh, it's the king. He's getting his Salk vaccine shot against polio in 1956. So the use of celebrity in terms of pushing public health campaigns is not new. And Elvis is not the first, but he's among the most handsome. So I've always liked to put him into my presentations. But then we've got Lady Gaga just this last weekend, and the One World Together at Home concert series that has been such a powerful, both I think a lifter of spirits, but also a really, really powerful work in terms of fundraising, right? And getting corporations to put their money where their mouth is. So are there similarities and differences? Absolutely. But one similarity, of course, is how do you galvanize resolve? And a lot of that is using popular figures. But in terms of one that I've heard a lot about in the media. So I prepared a few slides because I wanted to talk about some of the similarities and differences here, specifically with 1918 influenza, because it's being used a lot as a tool for anchoring. So I just want to run through a few things here, because just over 100 years ago, the etiology of influenza was really poorly understood. We knew when 1918 influenza started to arrive, the symptoms could be devastating and they could kill people within just a really, really short period of time. So people having shivering and headaches and pain in the legs, pain in kidneys, collapsing, high fever, hacking cough, this sort of thing. People were hacking up this really nasty, rusty sputum because there was a hemorrhaging of the nasal mucous membrane. So it was really quite an unpleasant thing to witness. But the worst symptom is what you're seeing here, this gentleman on the right, suffering from what's called heliotrope cyanosis, which means the lavender gray kind of coloring in his face and on his ears, when essentially people were drowning. They were drowning in their own lung fluid. So when we talk about 1918 influenza, there's sort of this general, like, we're not quite sure how many people died, and it was quite a long time ago. It was incredibly terrifying at the time. It was spreading quickly, and there was not an understanding of the virus, right? We have the power now to understand what we're up against. And of course, we're still understanding the types of effects it can have on the body and if we're actually able to have immunity. So there's a lot of questions still to be answered with COVID-19, but trying to put ourselves back 100 years ago, when at that point, we didn't have scanning electron microscopes that could let us see the virus. We didn't understand what was causing people to suffer and die like this. Whereas the term influenza has been around since the 18th century, and there was a knowledge of flu, but not flu like this. So 1918 influenza was really frightening because it had these three waves. And so there was an early wave in 1918, and the fall wave, which killed most of the people, and then again in 1919. So it came in these waves. We kept thinking it was over, and then it would come again, which was scary. But the part that was most terrifying is this. I promise this is the only graph you have or chart you have to look at today, but this W curve of mortality is super critical. So in the dotted line there, you're seeing flu season from years before the 1918 influenza, and you'll notice who is most likely to die. It's the vulnerable folks we usually think about, the really, really young and the elderly. And so people that tend to get sick from seasonal influenza, what we understand to be a regular flu season. But then you see 1918, and you see there's that spike. So this is the W curve we talk about. You can see it sort of looks like a W. And this was unusual. Who's highly at risk? People 20 to 40. They're dying in droves, pregnant women, people with tuberculosis, and a lot of marginalized individuals that were lacking access to healthcare. So this group is not one that we were used to seeing. So a similarity and a difference there is who's vulnerable and who do we need to be scared for was quite different at this time. And as I said, it traveled along the rail lines. By the fall of 1918, about 1 in 6 Canadians was sick, which is just terrifying. And so the mortality of the flu was huge, of course, but the morbidity was even higher, the number of people actually getting sick from it. So people unable to work and go to their jobs, people having to care for each other, kids having to care for their parents, like really quite shocking stuff was happening. But what started to happen, and again, you're gonna hear me list a list of things and you'll think, well, this sure sounds familiar. Public meetings got banned. The theaters closed, the schools shut their doors, colleges closed down, churches closed down, business hours started to get restricted, and some places tried to do quarantine. So we're seeing, and I really like this, there's some complaints from business owners start to come out saying, well, why is it we're limiting hours? You see in that top one, there was a complaint saying, well, is the flu more virulent after 4 p.m.? Why are we changing the hours of the store? What is that doing for people? And then questions again in 1918 asking, well, after this is all over, who's going to help bail out the small businesses? So again, these really, really common and themes that make complete sense for small business owners to be worried about, because there was no cure at the time. Good nursing care was the only remedy available. So think about now, what do we have? Of course, we have better medical interventions, but there's no acquired immunity yet. We don't have a vaccine yet. We have no prophylactic measures. We have to just care for each other and ensure that as few people as possible get the disease. Now, the other part that we see is the kind of ugly part of human nature, people trying to benefit from the flu. So when we think about folks that have been hoarding wipes and trying to sell them on Amazon, this sort of thing, this also isn't new. On the left here, you see a snake oil product being sold during 1918, Dr. Chase's menthol bag. Like, of course it'll work, just breathe in those nice vapors. Sounds a little bit like the plague doctor because it's exactly the same concept. You just smell the good camphor and everything will be fine. Breathe in the eucalyptus and don't worry about it. When of course we know that that had no effect, but might make you feel better, might make you feel like you're doing something. But my favorite advertisement I think ever is this one on the right here of perhaps you should buy a bicycle to fight the flu, because saying, don't take the streetcar, take your bike out anyway, avoid the contagion, which logically does make sense. But that last line there, you'll need a bicycle next spring anyway, and buying it will save money now. And you think, okay, so very clearly people are trying to make a living. That's a human thing. We need to do that. But when we're seeing people trying to profit off of, or business owners worried about their profits now, that's not new, and it makes sense. It's people trying to make their way and work their way through a really scary global event. But I have a couple more photos here that I wanted to show that I always think to myself, whenever I look at a black and white photograph, I always have to remember when they took it, it was in color, right? The world is in color in the past. These are not static items. This is a New York City street cleaner during the 1918 influenza. So when we talk about essential workers having to put themselves at risk, this also is not new. People that are working in these lower income jobs being forced to go to work no matter what, that's exactly what we're seeing 100 years ago as well. This is the San Francisco court doing open air proceedings. I just really enjoy this picture because of the idea that we're not quite sure what's going on with the flu, but of course, law and order must prevail. And so rather than having a Zoom meeting at the time, they just took everybody outside and still stood in close quarters. So of course, we know that this is not necessarily any better, but I do like the gentleman there who got his sort of sheriff star on, and we've got the lawyers fighting, but it's holding court in the open, just outside. But another image that's been evoked a lot recently, particularly in reference to New York, is this, the emergency isolation hospital. So you're seeing there is nurses, this is working on just off the front line during the First World War, but the idea of we don't have enough space, we have to do something quickly, we need to create this. So these images are being brought back, I think, and they are frightening. It is scary to see Central Park suddenly have a hospital in it, because that is a place of leisure. That's a place that's been set aside for another thing. So I understand the fear when we see those pictures, but when I saw the pictures of Central Park, I thought, well, that makes sense. In terms of just ensuring you have enough room for the caseload, it's ensuring that people aren't crammed into rooms together. It looks scary, but it is giving people a better chance to actually survive. So it is scary, but there is a precedent to it. And I think maybe that can help in terms of just quelling some of our personal fears as well. But this factor comes back to, these are some of these headlines I've been seeing, right? Is it worse? Is it better? It's not the flu. It's different. We're not, again, we can produce tons and tons of articles on this. And these are really, really interesting and really well-researched pieces. But I think a factor that's important to come back to is that what we're seeing in the media is this thing called anchoring. And this is part of social representation theory. It's just, how do we understand a new disease? We don't. Our brains can't handle it. So we attach it to something else. And we say, okay, well, is it better or worse than this other thing that we have some knowledge of? So rather than, when we say it's unprecedented, that sounds frightening, right? So it's easier to understand, and it's easier to take in and think, well, what can I do on any given day if it's in reference to something else? So we're trying to make a crisis understandable, right? And so comparisons are important because it gives us a way to build a framework to understand this. Now, I'm not above this. I read all this stuff too, and I panic, and then I remember, no, think about it. Think about, be a human, but also be a human in your house. But we have massive differences in medical infrastructure and technology. And the differences, of course, that are critical for 1918 influenza is that who's most vulnerable to infection is clearly different. People, in terms of the 20 to 40, of course, when people with comorbidities like tuberculosis or other existing medical conditions are, of course, still massively at risk. But a lot of people in 1918 didn't actually die of the flu. A lot of them died from secondary bacterial infections because we didn't yet have mass-produced antibiotics. There was also no federal health department in Canada at the time. The federal health department was formed in 1919 in reference to the fact that we did not have a central way of organizing. So having Health Canada now, that we can thank, I guess, the 1918 flu for helping to drive having a Dr. Theresa Tam or somebody at the head to give us some directives. So a lot of medical and social and political movements have been pushed forward by disease as well. So we are actually in a much, much stronger position to fight the invisible foe, not only because we have better interventions, we know what a virus is, et cetera, but because we can talk to each other and we can actually distribute information a lot quicker.
Thank you so much for that. Now, knowing what we do from past experiences, what can we do to get through and address the fear and stigma during COVID-19?
This is such an important question. I'm going to put up an image here that I've been looking at again and again. This is coming out of Massachusetts, but again, a quick Google will bring up tons of images like this. And so, as I said, it's a misnomer to call the 1918 influenza Spanish flu, but I have never seen anybody connecting influenza with an inherent sense of being Spanish. That is just not something that we have seen. So when we see COVID-19 being called the Chinese flu or Chinese disease, then we're starting to see a really dangerous use of language. And this is something that we have to address, we have to look straight in the face, and we have to think about, because I hope you've seen from some of the examples I've shown you, the stigma and the blame that can get attached to vulnerable groups, be they a religious difference, be they of a different sexual orientation, be they of a job choice you might not want for yourself, et cetera. These are people that are pushed to the margins and then told that it's their fault. And that kind of blaming does not move anybody forward. That kind of discourse is a waste of time. Now, as I said, we're in a stronger position in terms of mass communication and medical technology. And we know, we've heard, wash your hands, stay home, be careful, right? But the racism that we've started to see on social media has been really quite distressing. So a part of research project I'm part of right now has been doing a COVID-19 student survey. So surveying the University of Toronto student body. And we have our first set of results come back. We've done a big survey and then also done 30 individual interviews. And I asked students their take on, have you been seeing this? What is your take on the idea of it being a Chinese disease? And all but one of the 30 students I interviewed had either seen racist content online or had been involved in a racist incident in person against them. So that really was shocking. This growing number of discriminatory acts, people saying, I only feel comfortable going to the Korean grocers because I don't feel safe in the metro. Another student said, I have never been more acutely aware of my race. And another student told me that her mother had said to her, look, when all this is over, I need you to keep wearing your glasses and your mask because I don't want people to spit on you.
Oh my goodness.
Now how shocking, right? Like how shocking. You think to yourself, well, surely not today, surely not in Canada, but yes, today, and yes, in Canada, and yes, at the University of Toronto, on the campus in some cases. So it is our responsibility as Canadians and as humans really, just to really call out that racism because it's with, distance of 700 years going like, well, I guess because they thought I was, being punished by God and they didn't believe in that God. It's an ugly logic, but there's a way of going, well, I suppose at the time they thought that because they didn't know what we know now, right? Mm-hmm. Or, well, they didn't know about this. And so maybe their reaction makes sense in the context. And so when I say, think of the plague doctor kindly, I'm meaning because they only had a certain amount of information about bacteria. But in terms of racism and stigma, we've known for a long time that is not the way forward. And the fact that we're seeing it so obviously on social media, even in these apparently anodyne memes that are making jokes about the Chinese flu, it isn't funny. And we need to be calling that out because it is dangerous. And I worry for students, I worry for people in general. And so this article I thought was just a particularly powerful image of saying, my ethnicity is not a virus. And assuming that somebody is Chinese is racist anyway, but assuming then that they have anything to do with it or that they would be more susceptible or more likely to give it to you, it's horrifying. And we will be pulling apart the threads of these racist events, I think, for many, many years to come. So my feeling is the lesson is don't get complacent. Don't assume that it's not happening. And also don't assume you can't do anything just because you're sitting in your living room. These memes are coming from somewhere. Somebody else is sitting in their living room too. So if you see something being shared on social media, making a point of making a comment or, even an angry react does something, right? It has to show people that you're not okay with this, and by ignoring it and being silent, we are being complacent. And I think that's really, really frightening. So doing that project and speaking with students, I had to thank them again and again for their honesty because it's really easy to say, well, 10,000 people, 50,000 people, statistics get too overwhelming, which is why I try and bring the question in class back to individual people's stories and diaries and that sort of thing, because it's really critical to ensure that we're talking about individuals. But when I'm just having a Skype call with a student who's actually saying, this racist incident happened to me 3 weeks ago, it's really hard not to feel just really depressed about it. But instead, no, you have to use it as a galvanizing move towards action to ensure that we don't allow our story, when told by future historians, to be that we decided that it was a Chinese flu and we took some sort of nasty action to enforce that. So we need to be very careful to remember that we are all susceptible to this and it has nothing to do with ethnicity, nothing to do with a particular country.
Thanks, Madeline. It's a great message. Now, we had asked our audience to submit some questions in advance, so I've got a couple questions here from the audience. The first is, did societal habits and behaviors change after past pandemics? For example, there's a lot of talk today about how this pandemic will make people rethink, touching public things, for example, like interactive museum exhibits. Do you think our own habits and behaviors will change? Oh, we're frozen. Everyone just hang tight. She'll come back in soon. Oh,
hi there. Sorry, I heard past pandemics. So I thought I would just keep my face very still in case I got frozen.
It just froze for 1 second, but we're good.
Okay, good. Okay, so in terms of our things going to change? Yeah, and I think it's really easy to go, well, probably, but I think it's really, really important to think about what is it we can change. And I was thinking about this a little bit in terms of what has changed even in my lifetime, right? And so I thought about how when I was young, and I'm 32. So, when I was in elementary school, so not that long ago, there were folks that would have chickenpox parties and say, okay, your child has the pox, bring them on over. I want my kids to get it. I want them to sort of move through it. But now we have vaccines that take care of that. So there's no longer a need to expose your child to an infectious disease just because it has fairly mild effects for most kids, right? Or we used to, and this is a really interesting example, we used to spray everything with DDT to get rid of the mosquitoes that were moving malaria around, right? And malaria is still has some of the highest morbidity and mortality rates globally still. It's still a massive pandemic, massive problem. But during the 1940s, Disney put out sort of propaganda films that had the seven dwarves just merrily shooting DDT everywhere and just smoke out your homes and get rid of the winged scourge of malaria. So that's not that long ago. Again, we're talking about just in the 1940s, we're having, use as many chemicals as possible and spraying children down to get rid of the lice that spread typhus, et cetera. So a lot of what we learn, of course, is, oops, we overdid something, or we shouldn't be doing that, or now that we have an innovation, we don't need that anymore. But I've heard Dr. Fauci saying, it would be great if nobody shook hands ever again. So I think there is going to be certainly a difference in how we interact with each other. That's sort of the question of affect, how we interact, the idea of people, I've seen a lot of this, like, I'm a hugger, what am I going to do sort of thing. So I think there will be a negotiation of safety and of comfort and what that means for us. And if that means that we don't touch museum exhibits for a little while unless we wipe them down, I feel as though for sort of the public benefit, that doesn't seem like a huge loss, but I do worry about the cultural movements and the cultural ways of greeting one another, that we might end up with things changing quite a lot. But I think that's one that definitely remains to be seen. If we have a vaccine and we're all vaccinated against it and everybody becomes immune, I think probably pretty quickly we would see a lot of the things that we consider normal and things we want returning really quickly. So it feels like the jury's out a little bit, but I think a lot of that will have to do with how quickly we also remove restrictions, right?
We'll have to come back in like a year and talk to you again.
Yes, definitely.
Say whether or not we've observed this.
In person, wouldn't that be nice?
There you go. That would be wonderful. Just for our audience, if you do have any questions, feel free to submit them. I've got one more that came in advance. Considering recent protests against social distancing in the USA, for example, did any political polarization occur during the 1918 flu pandemic? And if so, did this polarization help lead to a second and third wave of the disease?
So what's really interesting is that the jury is still out a little bit on why the second wave is so fatal. And so there's been a lot of work done on if the virus had mutated, et cetera, and or was it human action? And so we don't know exactly why the second wave was so fatal yet, but of course there's still a lot of really good work being done on that. But I'm glad you asked about 1918 influenza specifically because of the masks. So masks had started to become a thing in the end of the 19th century in terms of masks, that look like the ones we think of, the sort of surgical masks. And so during an outbreak of pneumonic plague, plague in China in the beginning of the 20th century, we started to see the idea of the gauze mask over the face, and that became very common during the 1918 influenza. So certain provinces, again, there was no federal health agency, right? So Alberta, you had to wear them all the time, and certain cities, et cetera. But in the States, San Francisco had been an early adopter of the masks. So an outbreak happens in that fall wave in September. People are all required to wear masks, and fines were being handed out. I think this might be apocryphal, but I think the mayor got fined as well by the police for not wearing it to something. So there was a lot of push of like, everybody should be wearing them. And they were getting about 4 and 5 people to consistently wear them, which is great. And cases indeed went down sort of throughout October. And by November, the caseload was down. And people started to get antsy. There's that feeling of, well, it seems to be working, or it's worked, so maybe we can just stop doing this now. And so by December, there were actually public gatherings starting where people were saying, we don't want any more masks. Questions, and again, this sounds so familiar, questions like, well, isn't it just seasonal flu? Or isn't this just a lot of hype? What is it that we actually need to be doing? What are we doing this for? And there was this rather infamous op-ed run that the title was, what's the use? Then it was all about masking. And because a gentleman got sick, despite the fact that he had followed all the rules. So obviously it was masks problem, that it didn't work. And so hundreds of people started to gather, and there was a protest on December 16th, 1918. And a couple of weeks later, the highest caseload the city had seen erupted out. And so we can't say it's definitely this particular gathering, but the idea, of course, that keeping your masks on, it was helping, it was stopping the spread. So as flu was getting worse, people were taking off their masks anyway, because they're saying, well, this isn't helping, this is ridiculous. And there was actually an anti-mask league that got formed in early 1919. So again, it's that history not repeating but rhyming sort of thing. There's always people that don't want to follow the rules, always people that don't see the logic. And so again, rather than saying, well, they're fools, that's stupid, it's a question of what is it that they're chafing against? What is the problem? And so in the case of the San Franciscans in 1918, it was, we're not seeing the long-term effects, and we're annoyed about having to be these mandatory wearing. And so it becomes a question of, is it better to say, like we're kind of hearing from Health Canada today, choosing to wear it can maybe help you from spreading it to others, but we can't say it helps, it probably doesn't help as much about people not giving it to you, which I know that the messaging is still a little muddied and people are a little confused as to whether or not that should be, but mandatory sort of slamming the door, quarantine and lockdown type measures, people do push against them. And we are seeing that. But it's important to remember too that when you see the protest footage filmed from a camera phone and from maybe 15 stories above, when you see it's maybe 150 people maximum, it's good to remember that who's giving you that information on the success. There was, of course, the gentleman out in Vancouver who was leading a protest, and then we actually see it's maybe 19 people, not even in downtown Vancouver. And so we need to question, what are the sources we're seeing this from? But also remembering it is dangerous, and that people that are choosing to go out in public and to ignore these rules and to run onto the beaches, et cetera, as we're seeing in Florida, you can gamble with your own life, and that of course is your right, but gambling with other people's health, I think there's a moral importance to say, it might not be me that gets sick, but I could give it to somebody else who might have a comorbidity that I don't even know about, right? It could be something from asthma to diabetes to any type of autoimmune problem, or just the elderly and people who deserve our respect. So I think, of course, we're seeing some of these, again, the rhyming of history and some of these issues, but we can only control our own actions. And so if you know that you're washing your hands and you're following the rules correctly, then you're doing everything you can at this point.
Thank you. I think we have time for one more question.
Yeah.
Can you comment on social distancing techniques from past pandemics that still apply, and others that have since been proven ineffective? And I think you've touched on this a little bit already, but
yeah. I mean, the biggest thing, of course, is just if you are not in a room with people and contacting either things they're touching or the air they're breathing, then it's going to be better. Like we've seen all those wonderful illustrations of the dominoes falling until one's pulled, or the matchbook burning until one match is removed. The logic still stands. And this is why quarantine has worked in the past and why it's used to work. And it feels like rights are being taken away, but I just did a fellowship in Newfoundland for a couple of years, was researching some of their techniques, and they, the Narrows, it's literally a narrow area where ships can come in, and Newfoundland managed to avoid the 1830 cholera pandemic because they just said, nope, nobody's coming in unless they quarantine. And so future pandemics did hit Newfoundland, but the island itself of Newfoundland managed to not have any cholera cases, which would be a very vulnerable population. So the basic logic absolutely still stands, but thankfully we've moved on from other intervention techniques. I mean, if you read about treatments for other diseases like polio, it's all ice baths and oatmeal baths and all this sort of stuff. So we've moved away from a lot of sort of interventions that are, I guess, sort of reflexive, like once you have it, we'll try our best, versus the interventions of the prophylactic intervention of just keeping our distance.
Thank you. And actually one question just came in.
Yeah.
I'll ask you. Sorry, I'm just getting this. This is from Fiona. It says some discussion has occurred around live animal markets and emergent viral diseases. Are there other animals in past pandemics that were to blame by people at the time?
Yes, if we talk about birds have had a really bad rap. And so we talk about avian influenza pandemics, that sort of thing. Absolutely. So, I mean, we talk about influenza, we talk about swine flu, H1N1. So definitely. And there's been the work that was being done in the anthropological and epidemiological literature from sort of the mid 2000s on was mostly discussing the coming influenza of avian influenza. That was definitely the place of most fear. So the work that's being done currently on trying to figure out, are we talking about pangolins? Are we talking about bats? All this sort of work is critical for us to have a better understanding of how are our interventions or interruptions in some cases of the natural cycles of various animals, how is that actually affecting us? Because we tend to, when we talk about, are bats giving us Ebola and all this sort of fear, a lot of it has to do with, there's been animal reservoirs and vectors for many, many years, but it's our human interventions and interruption of those vectors and those relationships that tend to cause these spreads. So for instance, bubonic plague is still around. It's still around. Don't have to be too afraid of it. We know what to do now, but we have, groundhogs with that, and we have various other animals that are carrying certain diseases. So the biological work that's being done is so critical, and it needs to, again, be separated from some of that rhetoric that I was mentioning in terms of the idea of the Chinese disease. There's been a lot, even within our survey results, of people saying, well, I don't know, if they just didn't eat bats, maybe this wouldn't happen, but we need to know it's not that simple. So of course, studying some of those relationships and having a better understanding of human interactions with the environment is going to be really, really critical moving forward to prevent the next and the next and the next version of what we're seeing now.
Thank you. This has been fascinating. I'm just so happy. Thank you so much for joining us today,
Welcome.
for sharing your research, for sharing your expertise. So I just want to let the audience know that we're receiving a survey because we'd really love to hear everyone's feedback as we continue to plan these web-based activities. If you have more questions for Dr. Mant, you can follow her on Twitter at @MaddieMant, and we'll also put some information in the follow-up email so you can reach out to her. So I just want to thank you again and thank our audience for joining us, and we look forward to hosting everyone again at our next University of Toronto Mississauga online event. Thanks, Dr. Mann.
Thank you so much for having me. This was so much fun.
Great afternoon.